So unfortunately, one of the real driving philosophies we have here is to involve clinicians in our research and practice so that it's clinically relevant. And one of the disadvantages of that is that our clinicians have clinical responsibilities, and Jamie Remberger, who I assure you is much younger and better looking than me, is not able to be here because she's in the intensive care unit, not being looked after, but looking after a kid with a bone marrow transplant. So we're going to walk through here a few cases together, and in this, we're doing a bit of an experiment, both in terms of asking you what you would do in these settings, and in terms of really getting information about what people in our environment would do in these kinds of settings, independent of a pharmacogenetic test and with a pharmacogenetic test together. So in order to start this, I'm going to try and get a sense of poll all of you a little bit about who you are first. And many of you I know already, but many of you I don't know. So I'm going to ask broad categories, and then we're going to try and see how many people we have in different categories. So the least important people first. The people who are would count themselves as researchers in clinical pharmacology. It's not as many as I hoped. We needed to beat the bushes. Yeah. And the rest of them are all fired, right? How about nurses? Nurse practitioners, that's great. No, I'm sorry, could you keep your hands up? I need a number there. 1, 2, 3, 4, 5, 6, 7. That's any kind of nurse, right? And how about clinical lab people? People involved in clinical labs. 1, 2, 3, 4, 5. And then, I'm missing pharmacists. Okay, 1, 2, 3, 4, 5, 6, 7. And then I think we have a few physicians, practicing physicians here. Yeah. And then how about anybody I've missed? What categories have I missed? Anybody who didn't raise their hand for any reason? And what are you? Excuse me. So I'm a fellow in pharmacoepidemiology and informatics. Interesting. Good. And I guess we have some of our administrative office staff people here as well who are learning about this. Okay. So I'll take that as we have a good smattering of nurses, good smattering of pharmacists, and that's really good because in broad national surveys, those seem to be the two groups most likely to be actually on the ground in implementing this in the clinics. And then, of course, clinical and laboratory people will be important to that as well. So what you think about this is going to matter, and we're going to go through the questions, and then we are going to, heads up, ask people to justify some of their answers. So we're asking you to think here as well as just watch. So let's start with the first case here, and I don't need to do anything except click, right? Yeah, with this baby. Got it. So here's the first case. A 12-year-old boy with a history of inflammatory bowel disease was recently started on 6-mercaptopurine at a dose of 1 milligram a kilo. This would be normally what we do is if a kid this age presents with nasty inflammatory bowel disease, and this would present as bleeding, gastrointestinal bleeding, or unexplained abdominal pain with a little blood. He presents to the emergency room with fever and hypotension, and the CBC reveals a white blood cell count of 1.9 and an ANC, an absolute neutrophil count of 60. These are both low numbers. So here's a question for you on your little clickers here. So what could have caused the neutropenia? And remember, I gave all these possible ways of thinking about drug dose and drug prescribing before. So in this case, could it be that the dose of 6-mercaptopurine is incorrect and it should be only 0.5 milligrams per kilo? To go back, he got 1, right? 1 milligram per kilo. So should it have been 0.5? Many patients with sepsis present with neutropenia. It's a poor prognostic factor. I guess that's an understatement. It's not good to have a low white count if you're also septic. Your immune system needs white cells to work. Third, the patient may have absent TPMT activity. Now, absent is a big word in genetics. It means zero. No TPMT activity. And without getting into this gene too much, that is possible if you have a homozygous knockout. In other words, if both as your DNA are gone, then there's no activity. There are plenty of enzymes where there's reduced activity, but in this case, it's gone. So that's a possibility that would elevate the 6-MP levels, the 6-mercaptopurine levels, because it can't be cleared, and the thioguanine nucleotide concentrations. And we'll get into this more. Fourth, that the 6-mercaptopurine is protein bound. It's stuck to protein in the blood. And inflammatory bowel disease patients have low plasma protein concentrations. This is true, they do. And the concentration of free 6-mercaptopurine is too high as a result. Okay, so next, so we're in a pharmacogenetic conference, so nobody's very surprised that, this is what everybody said. Now, the other things are real possibilities, though. I guess, and in clinical practice, you would do different things if this was the case. Now, the standard recommended dose for 6-MP is 1 milligram per kilo, not 0.5, but you might, in many clinical settings, for example, if a kid was really sick and hold back the dose, and I've seen that done in many settings anyway. So it wouldn't be surprising if people did this. This is a clinical call, I think. I would be interested in what other people think about this. But if a patient's really septic and they have neutropenia, that means they're really, really, really sick. And you can tell a kid who's really, really, really sick. And last, the protein bound thing. There's so many things in clinical pharmacology that hang around protein binding, and I'll over-exaggerate it by saying nearly none of them matter. Very, very few. So let's keep going here. Okay, so let's get into why this is the case a bit more in this setting. So here's the azathioprine, and here's the metabolic pathway. So it's normally converted mostly by this route to methyl IMP. But if this is absent, then it goes down this route. I think it's not actually terribly important to know what all these little metabolites are. But the triinositol, the methylated pathway, this route. But this route becomes dominant if this route is absent. And the same thing is true of the thioguanine nucleotides. If this route is absent, then this route becomes dominant. And as a result, the major active metabolites down here are much greater. Is a simpler way of putting it. The 6-MP is blocked here. The thioguanine nucleotides are what's actively incorporated into DNA. And so when you look back at the dose people end up on in retrospective studies, it's this different. So this is the 6-MP dose here. You can see this is 250, 500. So you're just under 100 in a mutant, someone who had like a star 3 genotype. On the other hand, with a wild type, you're talking over 500 here. So a 5-fold difference in dose depending on pharmacogenetic genotype. Now, an important question to ask is, how many people are there in the population in this category? How many kids would be at risk here? So let me ask that question to some of the researchers in this group here. Does anybody know? I'm not going to give you the answer here. We're going to have to come up with it between a lot of you. So people like, unfortunately, I'm going to have to pick a clinical pharmacology fellow here, but I don't see one. Dr. Benson, you're hiding in the back there. Do you have any idea of this number? Here. About how many people is that in a population? Yeah, okay. 3%. Let's go to Dr. Thacker. Yeah, it's about 0.3, 0.5. So 1 in 200 kids. So you might say clinically irrelevant. And in fact, when this was presented to Congress, that was the first reaction, was 1 in 200 kids, does this matter? But then you realize what happens to these kids, which is basically death. Given a normal dose of 6-mercaptopurine, you get this profound granulocytopenia. If it's not picked up, they die. A very high percentage of these children die. So the consequence is very, very bad, even though the incidence is very, very low. Now, because of the way genetics works, the actual incidence of this, people who carry one variant allele, carry one knockout, actually runs at something like 8 to 9% in the population. So that's a pretty substantial number now of children who would have carry one reduced allele, who retrospectively would carry a slightly lower dose, but it's not nearly as scary as this down here. Okay. Any other points we want to make about that? I don't think so. Now, when we go next, it's going to require everybody to understand this. So are there any questions about this? Okay, here we go. Yeah. So the test was done, and the patient was found to have a TPMT 1-2 variant. So that means star 1 and all these things is normal. Star 2 is the variant. So they have one functional allele and one non-functional allele. So they would have only half of the DNA that's actually generating functional protein. So here's the question. Based on the clinical observations, in other words, the low white count on a normal dose, and the pharmacogenetic testing results, what would you do? Maintain the current dose and watch carefully. Start the patient on aggressive antibiotic therapy because they got a low white count. Or third, reduce the dose of 6-NP and monitor the patient's response. And fourth, change the therapy to a non-thiopurine immunosuppressant. Now, I could spend time on each of these, but I'd encourage you to think about this one. Now I need to go. I'm not going to go back. Here you go. We got it. The thing is, if I click twice, it stops it. I think I got it. Right. So this is interesting here. So starting the patient on aggressive antibiotic therapy, you might do, almost everybody should have said that, right? But you might do more than one thing here. You might start them on antibiotic therapy and lower the dose, which would be a very reasonable thing to do. So we're not going to ding these people at all, because they are really looking after the patient too. It would be very reasonable because now we have several alternatives to azathioprine in inflammatory bowel disease. For those who are cognoscenti in this area, you can use mycophenolate and other things. I mean, there are other approaches to inflammatory bowel disease and having to deal with this whole thing. Now, this is a good example of a situation where very often in clinical therapy, if there's a pharmacogenetic characteristic to a drug, people often say, this is too much, and just switch the drug completely to a non-pharmacogenetic thing so they don't have to deal with this stuff at all. So it's the pharmacogenetic paradigm is most valuable when there's a clear alternative dose or a clear alternative therapy. So you would move to something different. Where that's not the case, it's not nearly as valuable. So let's keep going here. And of course, what they want you to do here is reduce the dose of 6-mercaptopurine. Personally, I would have done that and this. So here's the summary of that. Here's the azathioprine. Normally, you would expect therapeutic levels and not to have a low white count, not to have granulocytopenia. But with deficient TPMT, you'd expect higher levels of the thiac-guanine nucleotides. Can I go back? I think people will get it. And have the low absolute neutrophil count and an increased risk of infection. Just a very simple way of depicting it. So this is what the CPIC guideline recommends. And this has come up a couple of times already. This is the Clinical Pharmacogenomic Implementation Consortium, which actually this came up. You can find it on PharmGKB, as Dr. Decker mentioned, or if you just plug CPIC, those letters and a drug into PubMed or Google search, you'll get the the 7 or 8 published guidelines that there are. And as Dr. Decker mentioned, these are endorsed by the American Society of Hospital Pharmacists. So in this particular situation, where there are elevated levels of thioguanine nucleotides, the recommendation in CPIC is to start with a 30 to 70% of the normal dose. So if that's normally 1, you would go down to 30% of that, and then adjust every 1 or 2 weeks based on myelosuppression and disease response. Now this is, how do you measure myelosuppression? You measure the white count. So this gets back to what I was saying earlier on. You're going to measure the white count anyway, but really what this is saying is you've got a heads up that there's someone you're going to follow more closely. So who, if you had to take everybody treated with azathioprine, which is a lot of inflammatory bowel disease is not rare, a lot of kids and a lot of adults, which ones do you monitor carefully, and which ones do you leave out there to kind of look after themselves and be checked every 6 months? So this is a way of telling that. And I think this is useful for that. On the other hand, if someone's a homozygous, if they have no TPMT activity, you do a 10-fold dose reduction, so from 1 to 0.1, and decrease the frequency of the dosing because you're changing metabolism, so you're changing the rate of elimination. Actually, you're changing the rate of generation of active metabolites. And you adjust every 2 to 4 weeks based on myelosuppression as above. And if you're dealing with a non-malignancy, now this is what, in this case, we were dealing with a non-malignancy. We were dealing with inflammatory bowel disease, not with acute lymphocytic leukemia, which is the other setting in which this is used. So you could consider an alternative agent, as I mentioned. So you could consider mycophenolate, or actually you could even consider a cyclosporin in some of these settings. Okay. Questions about that one? Okay. It's really because of the alternative therapies available. In the case of malignancies, you don't use cyclosporin or mycophenolate. You're pretty much stuck with some thioguanine. You can't get away from it. You could, in theory, go to one of the much more rarely used thioguanines, but we know much less about them and they're not widely used in clinical practice. People aren't familiar with them. But when you have inflammatory bowel disease, you have alternatives. That's why.